School podcast hosted by three paramedics from different countries. Live from the UK, Finland and Australia, this is Group Call.
Hi guys, thank you for tuning in. This episode is very special for a couple of one is here. That's the world's defibrillator. Show it to you slide. The second thing is that you can call us live 090 947 on WhatsApp and share interesting ECGs with us, and our expert Harrison Steed is going to do everything about those. So without further ado, let's get started. Harrison Steed, Timo Silva, good morning and good afternoon, gents.
Hello.
As I said before, this is basically led by Harrison, who is our... So, Mr. Steed, over to you.
G'day, everyone. Hello. So today we're going to talk a little bit about ECGs, and for some of you, it might be a bit of a sort of beginner's rundown. If you guys are listening to this, you're probably well up into the FOMED community and continuing education. So some of this you might already know, but some of this you might be a bit new to as well. So the first thing I want to discuss today was about one of the golden rules that I try to follow in ECG interpretation, and it's the rule that everything needs to be in proportion. So as I'm sure you're all aware, there's multiple criteria that we use with interpreting ECGs that are focused on set thresholds, set levels for ECG changes before we make a diagnosis or before they might qualify for a certain intervention. Obviously, the STEMI criteria that's used pretty much around the world is a pretty good example of this. So, there's 1 millimeter here and 2 millimeter there, and until they hit that threshold, that voltage, sometimes we don't really worry about it. We plug it into the monitor and the interpretation says, oh, well, the ST elevation is less than 1 mil, so they're fine. So sometimes, we relax our shoulders, we sort of up to hospital, they sit in the corner, and after a little while, eventually they might actually get that ST elevation. The problem with these thresholds is that they ignore patients with altered, physiology that might lead to false negatives or false positives. So an example of a false negative is someone, say, for example, like an elderly patient or an obese patient or someone else otherwise that has a low QRS voltage. They're also going to have a low ST segment voltage by comparison. So they might have an underlying MI that's missed by the STEMI criteria. And on the other side as well, there's plenty of false positive cath lab activations, left ventricular hypertrophy, hypertrophic cardiomyopathy, HOCM, that kind of thing, which have really, really massive QRS complexes and lead to a proportionally large ST deviation. But sometimes these aren't noticed and they're missed, and they're 2.6 mil elevation, it must be a STEMI. And they go to the cath lab and everything's fine. So another example of where proportion is really important in ECG findings and has actually started to change management over the last 10 years or so is diagnosing MI in left bundle branch block. So in 1996, they introduced the Scarbosa criteria. And what the Scarbosa criteria is basically a set of criteria that were to help diagnose the presence of a myocardial infarction in a left bundle branch block. Because as I'm sure you guys know, when you're looking at left bundle, there's always some big ST deviation. It can sometimes look pretty scary if you don't know what you're looking at. So the one I want to focus on is the third rule of the original Scarbosa criteria, looked at excessively discordant ST elevation. And what discordant means is if the QRS is one way, the ST segment and the T wave should be the other way. It's discordant, it's going the opposite direction. And that's normal. But excessively discordant was rated at greater than 5 millimeters of ST elevation in leads with a negative QRS complex. So say, for example, V1 through to V3 in a left bundle, you normally get a predominantly negative QRS complex, and it's going to go up with the T wave and the ST segment. And 5 millimeters was set as the threshold. Oh, it shouldn't be any higher than this. And if it's higher than that, it must be a STEMI. Well, then in 2012, Dr. Stephen Smith and some other people came out with what they call the modified Scarborough criteria. So it's about 10 years old now. And what changed was this excessively discordant ST elevation changed to a proportionally excessively discordant ST elevation. So instead of using 5 millimeters of elevation, they changed it to greater than 25% of the preceding S wave. Now, what does that mean? So greater than 25%, so say if the S wave is 10 millimeters, if the ST elevation is greater than 2.5 mils, then that would be proportionally discordant. And in that case, that would be classed as an MI that's needing urgent PCI. So you can see that's a big difference. So if someone's meeting that 25% with only 2.5 mils of elevation, in the previous criteria, they would have had to be 5 mils of elevation. But by the same token, someone might have 5 mils of elevation under the old criteria, might meet it. But if their S wave is 40 mil deep, just to throw a number out there, it's in proportion. So we need to look at everything as a whole. And when they brought out the modified Scarborough criteria, it improved a lot of diagnostic accuracy. And it's something that we need to sort of focus on there. Another one which is less sort of cut and dry is hyperacute T waves. I can sort of team have a little bit of a smile there. So hyperacute T waves are a bit of a funny one. Sometimes you ask people, all right, what's a hyperacute T wave? Oh, it's a big T wave. How big? I don't know, it's just big. There's not really any sort of set criteria that I've ever known that can really say this is what a hyperacute T wave is. Now, most T waves generally in the precordial leads are usually less than 10 mils, usually less than 5 mils. In the precordial leads, less than 5 mils and less than 10 in the chest leads. But where a hyperacute T wave comes into its own is it's really about the proportion of the preceding QRS, and that's what we really need to focus on. So you can have a tiny T wave, but if the QRS is small as well, that T wave can potentially be a hyperacute T wave. So you might have a quote unquote normal sized T wave. We'll say it's 8 mils for argument's sake. But if the QRS that it's following is 8 mils high as well, then in the right setting and the right symptoms, we would call that a hyperacute T wave. It's the same size as the QRS that's preceding it, and we shouldn't see that. Now, again, there's no real sort of set criteria yet. A good rule of thumb is, look, if it's the same height as the QRS, that's usually a big no-no. 75% is sort of where I go, yeah, look, that's where we need to start to be concerned. So yeah, it's a bit of a difficult one with that. There's no sort of set criteria yet, but what's your guys, outlooks from your countries? How's the paradigm with hyperacute T waves and proportion and stuff? Do you guys use any sort of criteria?
Timo?
No, we don't have any set criteria for it. And in terms of like the whole proportionate changes and all, I would say we are still trying to get there in terms of understanding it. The problem is that a lot of people do pattern recognition, and then that just means that they are counting the little boxes on the ECG strip, and then going by that. Luckily, we do send them out for a cardiologist to look at and call them up and ask them to see what's what, and then they'll make their diagnosis based on that and the symptoms that the patient is having. But there needs to be a paradigm shift away from the pattern recognition and towards the actual understanding of what is going on and comparing it to the history that the patient has, especially. In terms of hyperacute T waves, I think those are like a pet peeve for a lot of people I've seen. Changes in serum potassium are a thing that a lot of people are, like paramedics, are very afraid of, that their patient is having. And as soon as they see a T wave that is even slightly abnormal, you can be hyperacute, and especially if it's a bit peaked, then they go straight to hypokalemia, hypotassium levels, and then go from there. Like activate everything, press the big red button, start fluid, start everything. It needs a criteria, or it needs better understanding so that we can avoid those kinds of issues.
And
I think.
I will so concur with that, because what you said, Timo, is people count the small steps because they don't really understand the process, which greatly. Because pretty much the same here in the United in the squares we don't understand, which makes me slightly because it's turning the monitor on, turning the thinking off. Yeah, I will see the ECG, I will count the squares, yeah, fine, whatever. Great.
Yeah, and the argument with the hyperkalemic T waves, that's a whole other thing as well, recognizing what's hyperkalemia and what's hyperacute, and sometimes that can be difficult to sort of discern. It's not something I'm going to cover in this podcast, maybe perhaps in a future one if we ever get around to doing a second ECG one, because we could do days and days.
We promised that we will do. Okay, so we did two podcasts on posterior stroke, so maybe we will manage to. We will actually manage
maybe
Q&A.
Maybe
ECG.
absolutely.
Yeah, second. Anyway,
an idea I had, and just to sort of prompt a bit of thought in the viewers, is let's picture two patients. Let's picture Timu is young and fit and healthy. Okay,
and where are you going?
I'm showing my affection. And look, I'll use the example of myself, but let's picture someone who quite a bariatric patient, very large.
I knew that you wanted to say something about old. Okay, so yeah, feel free. I'm here.
I'll leave you alone for this one, Alex. I know I give you a lot of shit. So let's picture a young, fit, healthy patient, and let's picture the same age patient with the same heart, but they've got all this adipose tissue around them. Okay, and they're suffering from the same symptoms, and they're both having an MI, and they've both got the same territory of myocardium at risk. Everything apart from their body size is exactly the same. Let's do an ECG on both of those patients. We do an ECG on Timu, who's fit and muscular and, wink, wink, nudge, nudge. Anyway, so we do an ECG on Timu and we find ST elevation, and we find it greater than 1 mil in these leads, and we say, all right, Timu is having a STEMI, and let's take him to the cath lab. We do the same ECG on that bariatric patient. They've got exactly the same heart, exactly the same thing wrong with them. But because those leads are having to look through so much adipose tissue, everything gets a bit smaller. All the QRS voltages get lower, and then the ST segment gets lower, and the T wave gets lower. And by proportion, their ST elevation is going to be lower and perhaps less than the threshold, even though exactly the same thing is happening to this patient, and they need the exact same treatment. They both need PCI. One is going to be not recognized by STEMI criteria or by any criteria that uses a set threshold. And this is just something, a thought experiment. Like, I don't know of any particular study that looked at, well, how often do obese patients get missed in STEMI criteria, but they have been shown to have lower QRS voltages. And we know that proportion is a real key factor in this. So is it something that you guys have ever considered when interpreting an ECG?
Yeah, so yes and no. We in the United Kingdom, we don't have a set way of putting the limbs, especially precordial leads, and trying to think about the actual, what's the word, influence that on your, which is actually quite annoying. And by the way, I recorded quite interesting video on ECG technical limbs and how the actual electrode placement and thoracic cage impedance can change. So if you want to watch it, guys, go to the www.groupcall.uk webpage and find this video on 10 tips for ECGs. Yeah, it's quite interesting because we consider those factors you mentioned, Harrison, and that's a shame because we have evidence based. We know that actual impedance of the voltages, right? Timo?
Yeah, I completely agree with that. I'm also surprised that there hasn't been much, at least that I know of, like technical development to combat that issue. Because when we use our defibrillators, like for example the Soul, like before you give the shock, it will basically calculate the resistance between the electrodes, and it will change the amount of current given based on that. So a more obese patient is going to get more current, so that their heart will get the same as, for example, I would get, because that doesn't really change based on their body mass and stuff like that. So it's interesting to me that, like, I don't know, could we pop on the defibrillator leads, let the machine calculate the resistance, then put the ECG leads on and have it adjust the voltages on the ECG? I don't know. I'm not that tech savvy, but maybe in the future, the machine will do some of the work for us. But at the moment, yeah, we definitely should consider our patient more, not just the machine.
Yeah,
absolutely.
And also, I will do here, guys, because we discussed my colleagues for female patients, and I'm not even saying yet. If you place the leads, should they go under the breast, over the breast, and naturally I understand, and I don't. They go under the breast. I met a lot of patients who place over the, it will change the morphology of the voltage of the ECG. And again, if you with manufacturers' recommendations, then they say under the breast, but again, you will see lots of people putting them, and it matters. Treat the patient, not just think the physics behind G.
Absolutely, and the other issue with that is as well is, it's sort of walking on eggshells as three males talking about this, but it is a important thing to mention, is that the female anatomy is very different between each female. Obviously, there might be larger breast anatomy, might be smaller, and it might be in a different spot as well. So if you're placing the leads just under the breast tissue by habit, it might be in that right position for some patients, and it might be significantly lower for other patients.
True.
So you've kind of got to weigh up, do I put the ECG on the breast in the right spot? It's traveling through a little bit more tissue, but that's okay. It's in the right spot. Versus, I don't want to go on the breast, so I'm going to go lower, and you might be, 7th intercostal down, and you're getting a very different picture, and it's not really a diagnostic ECG. So definitely something else to consider as well.
Okay.
Yeah. So the next one, point number 2. Now, look, I'm going to make this a quick one. Point number 2, things you need to know about ECGs is read the OMI manifesto. So for those that are not aware, I can't, I see Timo clapping, good. I can't possibly summarize this body of work in a short period of a podcast, let alone its own podcast. But for those that aren't aware, the OMI manifesto is written by 3 very intelligent people. And I dare say...
You, Timo, and me.
it's not. No, they're slightly.
No, I hired a ghostwriter.
No. So three very smart people that are not ourselves. And I dare say, if you're watching this podcast and you're aware of us, you're probably aware of these guys. So Pendle Myers, Scott Weingart, and Stephen Smith. So if you've ever heard of MCRIT, Dr. Smith's ECG blog, these kind of FOAMed resources, you know about these guys. So the only part of the OMI manifesto that I will read is the first sentence. And I think that's really important, and it flows on very well from the discussion about proportion that we just had. So the sentence goes, the current guideline recommended paradigm of acute myocardial infarction management is irreversibly flawed and has prevented meaningful progress in the science of emergent reperfusion therapy over the past 25 years. That's pretty firm language, okay? But if you read the OMI manifesto, and what OMI stands for is that we're trying to change the terminology away from STEMI. Because when we say STEMI, we think ST elevation because it's in the name, okay? And there's other terms get thrown around called STEMI mimics and STEMI equivalents and near STEMI and subtle STEMI. But we can't get away from this sexy term of STEMI. Our minds are completely focused on STEMI.
Mm-hmm.
And the problem with this is if all you know is STEMI, then all you'll look for is STEMI and all you will find is STEMI. About 25 to 30% of patients that need a cath lab, emergent cath lab therapy, emergent PCI, 25 to 30% of them will be missed by using the STEMI criteria. Okay. Now, whether it be the proportion that we mentioned before, whether it be other signs that we need to look for, either way, if we're only focusing on this STEMI, we're missing a quarter, 1 in 4 of our patients that need this care. And it might be quite interesting because people, we all know, STEMI's the really, really bad one, but N-STEMI's, it's okay. They can wait and they can get cath lab in the morning. The problem with this is patients with N-STEMI that are having an occlusion versus patients with STEMI that are having an occlusion. Patients with N-STEMI actually have worse outcomes. And it doesn't make sense with all this, stuff we know about STEMI. That's the bad one. Well, part of the reason why these patients have worse outcomes is because, for lack of a better term, we don't worry about them as much.
Mm-hmm.
We don't get them to the cath lab as soon. We're not as aggressive with our management. We might be slower getting our trops. Where, depending on their presentation, we might be less aggressive with the pharmacological management. All of these things, but they're going to have worse outcomes because we're missing them. So, as I said, I'm not going to go through the whole OMI manifesto, but I really implore everyone to read it. It's excellent.
In the description.
Absolutely, we'll leave the link. Yep, and you can find it from multiple different resources. But it goes over all these other findings that we can look for in MI, and I do cognitively try to use the term MI, myocardial infarction, rather than STEMI, because we need to change this. Change this terminology, and it will change the culture around it. So some of the things it discusses looking for is, using certain criteria in, early repolarization. What's early repol versus what's actually STEMI? Another excellent one is looking at the inferior leads in AVL. They talk about any ST elevation in the inferior leads, no matter how modest, 0.5 mil, 0.3, whatever. If that's also followed by ST depression in AVL, again, no matter how modest, in the right setting, with someone with compatible symptoms, that's an inferior MI until proven otherwise. Don't worry about your criteria. If you've got elevation in your inferior leads, depression in AVL, that's an MI until you prove. Yeah, so look, another example of something from the OMI manifesto that is quite good is talking about the identification of posterior MI.
Mm-hmm.
So we often think with posterior, we'll chuck on the posterior leads, chuck on V7, 8, and 9, and that'll identify it. But the problem with that is sometimes that can sort of talk us out of it. Okay, we mentioned before about having to go through more tissue, lower QRS voltages, and that kind of thing. Well, when we're looking from the back, we're looking through all this lung tissue, and we're going to see lower ST segments. And if we don't see the 0.5 that you might want to see in posterior, in posterior leads and might talk you out of that diagnosis. So what the OMI manifesto talks about with posterior is the ST depression throughout the chest leads, and specifically through V1 to V4. And what we don't want to see, but if we do see it, is if the highest level of depression is in V1 through to V4, in compatible symptoms with acute coronary syndrome, that's a posterior MI until proven otherwise. And proven otherwise by bloods, proven otherwise by a clear cath, whatever it might be. But if someone's presenting with ACS symptoms and they've got ST depression and it's highest in V1 through to V4, we're calling that a posterior. Don't worry about putting the posterior leads on if you see that, because you're more likely to talk yourself out of it. Okay, that's what we need to go off. And as I said, there's so many other things. There's De Winter T wave. There's hyperacute that we mentioned before. All sorts of things that are in this OMI manifesto that we need to be across to be able to give better care to our patients. Now, I don't think I mentioned it before. What the hell does OMI mean? So OMI is occlusion myocardial infarction. And it's a really important change in terminology. It's getting away from calling it something based on a set criteria, like the ST segment, and we're changing it to call it depending on what is actually causing it. What's actually causing this problem? Is it an occlusion causing this myocardial infarction, or is it not an occlusion causing this myocardial infarction, a NOMI? So this changed from STEMI and STEMI to OMI, NOMI, I think is a really, really important one. Timo, it looks like you've read the OMI manifesto. Alex, have you read it? And if not, I'll be angry at you.
You're angry at me.
Oh no, what? Okay, so Alex has homework then.
Alex has homework for the next episode. Read the OMI manifesto.
Manifesto, yep.
Yes. No, look, it's really, really good. And there's all sorts of references in there. I'm not going to say any more about it because it's super detailed. You guys need to read it. Yeah, viewers and Alex.
There's also good stuff on Dr. Smith's own blog about like ST depression failing to localize patient cases where there was no STEMI criteria, a troponin was missed, a diagnosis was missed, the depression did not localize, and then few days later, when they received the cath, it was 90% stenosis. So there you go. Also, like if our viewers, well, because our viewers know of Life in the Fast Lane, I bet their article in the ECG library about myocardial infarction talks about ST depression, and especially like Harrison mentioned about the inferior and the AVL bits. That's pointing towards like reciprocal changes. So those are obviously opposite leads. So then if there is a very localized depression in one lead, then even the slightest elevation in the opposing leads is quite indicative of an MI.
Absolutely.
Cool.
Yeah.
Go to the next one.
No worries. So next one, I'm going to hand this over to Timu because he's a bit smarter than I am in terms of cellular stuff. So this is a really, really interesting one. And to be honest, I only learnt about this, say about 12 months ago. I was working with a student and we were talking about ECGs, and he was very inquisitive and he wanted to know why. Why is this like this? Why is this like that? And he asked me, well, I know, we get ST changes in myocardial infarction, but why? What's actually happening to the ST segment? What's actually happening to the heart to cause the ST segment to change like that? And the really interesting answer is it's not real. ST segment elevation and depression is fake.
Doesn't exist.
It's
It's a myth.
So I'm going to hand over. Bear with us. This might sound like heresy, but we'll hand over to Timu to discuss this point. It's really interesting.
Doctor.
Yeah. So yeah, ST segment changes are a myth. What changes is not the ST segment, is everything else around it. Alex, I sent you 2 pictures. You've got the one with the hearts and the localized damages.
Is that this one? The other one.
Do that one
Yeah,
next.
okay, got it. Yep.
So basically, I'm not going to go into too in depth. No, the third one. Sorry, too in depth about what actually why there are like damage currents, so to speak. But there are. So when you've got like an area of ischemia, you will send out current. That's like the damage current, and that will change everything in the ECG. It should be the third picture, Alex.
I don't have the third one, sorry. I have only this one. The repolarized and then axis. Bear with.
Okay.
I need to find it. Back to the.
My name's Tori.
Yeah. No worries.
Oh.
Depression. He's on.
Yeah. So let's talk about this one first then. So ST depression in the ST segment can have actually like different morphologies. And Harrison was just talking about ST depression. But the one thing to know here specifically is the upsloping ST depression. Like if you took an ECG of me, I would have, well, no, probably not ST depression per se. I might have it, but my ST segment is very, very likely going to be upsloping, which is like the what was the term you used, Harrison? Like for young males.
Early repolarization.
Yes, that's the one. But that's another things can present as upsloping as non-specific for myocardial ischemia. But then the downsloping horizontal ones are much more common in ischemia. Did you get the pictures, Alex?
I'm now. Seconds.
Yeah. All right.
Yeah, you can chat along. We'll just.
Yeah. And anyway, in the picture that Alex is hopefully going to show us soon, there is a like if the area of ischemia is not transmural, it's not through the heart, it's just a part of it. It will send damage currents basically away, towards the electrode watching, and it will do that all the time, no matter what state of depolarization or repolarization the heart, the muscle is in. It will send out those currents, and that will change the baseline. But when the heart is like fully during and then afterwards, and before and after, you get currents towards the electrode, which will raise the baseline, and then the ST segment will be at the regular one, and then the other picture, the damage currents will be sending it away from the electrode, which means that the isoelectric line will drop, and then you get the repolarization, which is the red bit. The ST segment will be at its original place, and then again damage currents away from the electrode, dropping down the baseline, which leads to an elevated ST segment. So why does this matter? Why are we even discussing this? The ST segment is changed, and we can see that it's either depressed or elevated. Does it really matter that things around it have changed because the diagnosis is the same? Well, it's in my opinion, and I want to see what you guys think. This is going back to that pattern recognition and versus understanding. So understanding the physiology behind the ECG will let us interpret any given number of cases based on what's changed, whereas the pattern recognition will just make us feel like we're doing like this, like if you've had it in like newspapers, like spot 70 mistakes or like find the differences, and then you're just like scrolling through Life in the Fast Lane ECG library trying to find that same looking ECG, and then you diagnose a Wellens syndrome just because this looks a bit same, but it's not really. You activate the cath lab, and then the cardiologist is going to be really mad at you because you did not actually look at the ECG. You just looked at the perceived changes or the perceived mistakes. And don't get me wrong, in my opinion, pattern recognition does have its place in the very hyperacute setting, in the quickest of jobs, like the Cat A, Cat 1, like the high risk patients. Looking at the ECG quickly, especially if it's not cardiac, if it's something else, looking at it quickly, seeing that it's pretty much okay, can be good. Like, you don't want to waste time on the ECG too much. But then moving down from that, and then also like dealing with cardiac patients, it becomes more and more important that you actually go through it methodically. Like, are we seeing a P wave? What's the QRS like? Is everything in proportion? What's the ST segment? What does the T wave look like? Is every P wave followed by a QRS complex? Like, are all the times normal? Are they abnormal? Stuff like that.
The changes that we were talking about with that diagram, with that positive charge moving out from that ischemic territory, really comes down to potassium, doesn't it, Timu?
Yeah.
That's really the main player here. So when that tissue goes ischemic, it starts leaking potassium. And we're not going to go into the different channels and voltage gating, all that kind of stuff. It's just over the scope of what we're trying to achieve today. But those changes result in a lot of different things. So it results in delayed repolarization and all sorts of other things. So when you start to get that understanding, like when I went through uni and learn the resting membrane potential, I'm like, why am I going to need to know the cellular voltage to treat this patient in front of me? They're more than just a collection of cells. But it really helps to sort of understand different things. It helps to understand that, all right, yeah, this is ischemic because this is what's happening. And then this is what I would expect to see. Do I see that or not? Another sign of ischemia can be a prolonged QT interval because of that leakage of potassium and that delayed repolarization. Well, what about when I'm seeing a short QT interval? Okay, well, that's a bit strange. I know that short QT can be affected by other electrolytes, calcium, for example, and I know there's changes that are resulting from potassium and all that sort of stuff. So maybe there's something else going on. Having a good understanding can really help you work out when things aren't quite right. When 9 out of 10 things are fitting your picture and one's not. So, yeah. No, really interesting point, I think.
Really one thing. Yeah, really good one. Next one, shall we?
No worries. Yeah, so the next one, again, a bit more of a basic one. We've talked a lot about sort of, cellular stuff and more clinical stuff. This one's just cardiac access. Now, I say just cardiac access. A lot of the people, myself included, we didn't get taught this at uni. They said, hey, look, cardiac access is a thing and axis deviation is a thing. But we're not going to tell you because we're not going to quiz you on it. You don't need to know about it. That's pretty much the outlook of some educational providers. I think it's really helpful to understand for the same point I just mentioned, is like you have that really good understanding of what's normal. Then you can understand when it's abnormal and why it's abnormal. So have you guys, do you guys get taught axis deviations at uni back in the 40s, Alex?
30s. No, we didn't have horses and...
Was it still putting the hands in the buckets?
Yeah, just
or something?
like wet your fingers and measure different points.
That's exactly.
We got taught it just a bit.
Yeah. So look, as a very high level overview, the cardiac axis is the direction of the electrical flow in the heart. So any deviation, any change to the normal can be a sign of a couple of different things. So it could be myocardial infarction can cause it, ventricular hypertrophy or ventricular strain, either left or right. Bundle branch blocks can change it. ventricular rhythms, all sorts of stuff can cause an axis deviation. And to really know about the axis and understand the axis, we need to know where the leads are looking. And it might seem obvious because, at uni, many people are taught and still taught that, you just draw a box around these three, that's inferior. And there's like a Sally algorithm or anagram that people learn, and all these different things that go, right, those ones are inferior, those ones are septal, those ones are anterior, these ones are lateral. But we don't often teach in sort of further detail, and knowing where they look really helps us understand more about these changes. So what's really important about ECG interpretation, another thing that's important, is you need to think of each lead as if you're sort of standing at that point looking at the heart. We say this lead looks at this part. Well, yeah, that specific lead is you're standing there, you've got your eyes or a camera looking at that point. The precordial leads are really easy to know because they're pretty much looking where we stick them on the chest. Where you stick V1, that's the point that V1 is looking. Where you stick V2, yada, yada, yada. Goes back to what we mentioned before about if you're doing an ECG on a female with, larger breast anatomy and you're having to sort of put it lower, that's going to alter the perception of what that lead's looking at. Instead of going this way, it's sort of looking up at a different part of the heart. But yeah, the chest leads are easy. Go done. We know where they're looking. The limb leads are a little bit less intuitive. So Alex is going to chuck up a picture of Einthoven's triangle.
Here you go.
Very shortly, lovely. And yeah, so Einthoven's triangle is something they said, hey, look, when ECGs were invented, yada, 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 this is the basis. And I never really understood Einthoven's triangle. It just wasn't intuitive to me. It helps in working out, between which specific electrodes the leads are, but it didn't really help me understand where the leads are actually looking. So the way that I use, and it's, there's variants that you can find online, but the way that I use is I think about food reasonably often. So what we'll start off by doing is we draw a pizza. So there'll be a graphic that Alex will put up here. We'll keep it nice and simple. We'll draw 8 even slices on this pizza. Yeah, just the nice plain one. So let's just start with that nice and easy, nice and equal. Yep. And we need to picture the patient's heart in the middle of this box, okay? So the heart's in the middle and we're looking at the heart. Now, picture our patient is kind of like the Vitruvian man. Is standing up with his legs together and he's got his arms up at different angles. He's kind of trying to wave out to someone. He's trying to wave out to you to understand this is where my axis is. So from the this is really stupid analogy.
I really like it.
From the perspective of you looking at the patient, he or she's facing you. Where's his left arm going to be? His left arm is going to be on your right side. So the AVL left is on his left arm. AVR right is on his right arm. Now, where might AVF be? So AVF, you just look at their feet. So that's going to be the line pointing directly down. So where do leads 1, 2, and 3 go? So the way I tell students and how to understand this is what's an ECG doing? It's looking at the heart. Well, where's the heart for the vast majority of patients? It's on the left. So let's start the leftmost line and we just go 1, 2, 3. We go 1, clockwise around to the next one, go 2, clockwise around to the next one. That's already taken by AVF, so we skip it. Next around, and we go lead 3. Now, Alex will chuck up the next picture here. You'll have something.
Here you go.
Lovely. So it'll look a little bit like this. Now, this image is from Life in the Fast Lane. So Jared Fennessy put up this article here. Theirs obviously looks a little bit different. The angles are looking at it a bit different. That's fine. It's a bit more exact. It's fine for what we need to know. And you'll also notice that they do the AVF rather than looking at their feet, is looking at their fiddly bits. Do what, and that's what he says in this post, which is great. Do whatever works for you. It doesn't matter. It's all looking at the same stuff. Okay, so now we'll go away from that diagram and let's think about something really fundamental. What does it mean on an ECG when you see a wave that goes up from the isoelectric line. It doesn't matter about which wave it is, P wave, Q wave, doesn't matter. When you see a wave that goes up, what that means is that there's positive charge going towards that lead, basically. So getting that depolarization, that positive charge going towards that lead, you'll have a positive deflection. If positive charge is going away from that lead, it's going to be a negative deflection. And then in repolarization, when you get the negative charge, it's reversed. So negative towards a lead will be negative, and negative away from will be positive. Pretty simple. Here's a pen. Now, guys, you can only give me one piece of information. You can only tell how far away this pen is from you. No, you don't need the pen. You can do it if you like. Go for it. But you can only tell me where this pen is in terms of how close it is to you. So this is its normal spot. You can tell me whether it's going towards you, or you can tell me whether it's going away from you, or you can tell me, like, when it's going side to side, it's not really going towards or away. You don't really know. It's just kind of in the same spot. So if this is a positive charge and it's going towards you, what's that going to look like on an ECG?
Yeah.
Positive. Yeah. Positive deflection. And same negative. You guys are reasonably smart, so I'm satisfied that you guys passed the test there. Okay. Now, okay, let's bundle all this together and we'll look at cardiac axis. The two leads, to do this the most basic way, and there are more complicated ways, but to do this the most basic way, so we look at two leads. We look at lead 1 and we look at lead AVF. Now we'll put up the diagram again of the completed circle there, and we'll look at where lead 1 looks directly from that side at the 3 o'clock position, and lead AVF looks at the 6 o'clock position. Now, why might we use these two leads? In this method of axis deviation and working out the axis, it's really just a process of elimination. We want to wipe out as much information that we don't need as possible, okay? So we'll head back to me, we'll do our pen, we'll picture that this is lead 1, okay? So you're looking at lead 1, this is the center, this is where the heart is, and you see lead 1 is going towards you. Lead 1's mostly positive, isn't it? Most of the time. Lead 1's going up, which means there's positive going towards. So that means from that center point on that completed diagram, it must be on that half of the circle. I don't know if I'm doing it the right side. I don't know which way my camera's inverted, if my camera's inverted on the stream, but it's from that center point, the charge is going towards lead 1, isn't it? Because it's positive. So we know it must be on one of those right two quadrants. And we don't worry about the left side, okay? We know it's going towards lead 1. And then we do the same thing. We look at lead AVF and we look at, is that going positive, mostly positive or mostly negative? And what I mean by that is you look at the QRS. Is it mostly positive or is it mostly negative or is it kind of in the middle? Now, for most people, lead AVF will be doing the same thing. It'll be going towards lead, it'll be positive. So we know that it's in that latter half of those 4 quadrants. So you can color them in, you can do whatever you want, but you look at where those 2 points overlap. We know it's on the lead 1 side of the horizontal half, and we know it's on the AVF side, the lower side of that one there. So it's facing down towards lead 2, which is the normal cardiac axis. And this is why we use lead 2 as our main monitoring lead, because for the vast majority of patients, that is the normal cardiac axis, is roughly towards lead 2. So you're going to get the most deviation. It's going to be the easiest one to see. All right, how do we do this a little bit easier? Easiest way I do is 2 thumbs. Lead, and I think I'm inverted, so I'm going to do it this way. That should be on the stream, should be on the left-hand side, and that should be on the right-hand side. 2 hands, 2 thumbs. Lead 1 and lead AVF. Is lead 1 up or is it down? If it's up, thumbs up. Good. It's going up. Is lead AVF up? Yep, it's up. 2 thumbs up. That's good. That's normal. No axis deviation. 2 thumbs up. Good. I'm sure you can understand what 2 thumbs up means. Yeah? Cool. Now, let's do it another way. Let's say lead 1's facing up. Thumbs up. But lead AVF is facing down. Okay? Now, to work out which way it's deviated, you just look at which thumb's facing up. Left thumb up, left axis deviation. Okay? Lead AVF is going to be facing down in left axis deviation. Now, how do we know that's left axis deviation? Let's just look at our thumbs. Is it left thumb up, right thumb down? Left thumb up, left axis. Easy. Simple, simple, simple. You're smart people. I'm sure you can probably work out what right axis deviation is going to look like. So lead 1's going to be facing down. Lead AVF is going to be facing up. Right thumb up, right axis deviation. Simple, yeah?
Cool.
Now, Alex. Alex, because...
It's I thought this.
No. Well, all right, I'll let you do this one, Alex, okay? Because you're a reasonably smart person, okay?
No pressure.
So get your thumbs out, all right? Now, lead 1's facing down. Lead AVF is facing down. What does 2 thumbs down mean?
No.
Not good. Not good. Bad. Very, very bad.
Did I pass?
You passed the trick.
Amazing.
Yeah, the patient didn't.
You get 2, Alex, you get 2 thumbs up.
Yeah.
But 2 thumbs down if they're both negative.
Yeah.
Now, why is it 2 thumbs down? Well, I mentioned before that the normal cardiac axis is 2 thumbs up going towards lead 2.
Mm-hmm.
All right, it's coming from the SA node, going down, all that sort of stuff, going towards lead 2. 2 thumbs down means it's going the other way. Now, what sort of rhythms go the other way? What sort of rhythms originate from down there and go up? Ventricular rhythms. VT might be ventricular escape rhythm, whatever it is. There's other conditions as well, but if you see 2 thumbs down, that's bad, okay?
Mm-hmm.
That's what we call extreme right axis deviation or extreme deviation. So that's a really basic high-level overview, just using 4 quadrants and 2 thumbs, be able to work out where things are deviated, okay?
That's really cool.
Yeah, it's nice and simple. Now, what can it mean, okay? Look, left axis deviation, usually seen left bundle branch block, usually seen left ventricular hypertrophy. There's all sorts of things that cause left axis deviation. It's also seen often in inferior MI because that bottom right part is infarcted. So most of the electricity is going the other way towards the upper left side. Now, right axis deviation, that can be seen in pulmonary embolism or otherwise just any sort of right ventricular strain that moves towards the right. You can see it in a lateral MI because the opposite up here is affected. So the bulk of the electricity is going to be more going towards that way. You can also see it in pediatrics as well. So the pediatric ECG, which is a whole nother box of frogs, that starts off more rightwards. And as someone grows up, the axis moves to the left as well. So if you're doing 12 leads on 5-year-olds and see right axis deviation, left thumb down, right thumb up, it's generally going to be pretty normal for someone of that age. But that's a real basic rundown.
Can I just one thing?
Absolutely.
In third trimester in pregnant ladies.
Another one as well. And why is that, Alex?
Due to the physiology of the pregnancy, actual physical of the heart, because think about the fetus and compression of the diaphragm and all the are lifted or shifted up in the heart, slightly deviates.
Exactly right. So, and this is going back to this, if you have a really good understanding of what is changing, you can work this stuff out. If Alex tells you, you get left axis deviation in pregnancy, and you know that, someone's pregnant and physiology is changing and that's turning, it's sort of becoming more horizontal, more towards the left, you can work it out. You don't need to know that it's deviated, but actually more correctly, if you were to just ask someone, where would the axis be in a pregnant patient?
Yeah.
You can kind of just piece it together. Well, it makes more sense. It would go to the left. So this is where all this sort of comes in. So
cool.
Is that something that thumb trick? Is that something you guys had ever seen, heard of?
I never had used. That was so cool.
No, the only trick I've heard is to basically look at the limb leads and find the one that has the highest QRS peak compared to everything else around it. And then that is basically closest to where the axis is pointing. So if it's 2, good, it's pretty much normal. And then when it starts moving, like if it becomes lead 1, then that is starting to move towards that left axis. If it's starting to move towards lead 3, it's moving over to the right side, stuff like that. But the thumb trick is, I think, even easier, because sometimes it can be hard to figure out like which is the highest one, and then there's other considerations like we just previously discussed, like obesity, lead placement. If the leads are not in the right place, the QRS will be different, because obviously the leads are not where they're supposed to be. So I like the thumb trick a lot more.
And Timo, that's another really good way of doing it, is sort of finding out the QRS. The problem that, at least in the monitors that we use, and a lot of pre-hospital monitors, when you print off the ECG, you often get like a letterbox. It cuts off, so you might not know what the tallest one is.
Yeah, true.
But it does the exact same thing. Now we know about how it works. Our viewers know about how it works. You guys can kind of piece it together. Well, why is it going to be highest in that one? Well, that's because where the bulk of the electricity is going. So if it's highest in lead 3, that's because that's where most of it's facing. Another method we didn't really mention is, well, what happens when it's kind of biphasic? What happens when it goes up and down and it's equal parts? What I usually do is I go, it's kind of in the middle. So it means it's sort of on the border. So you find out whatever your other thumb is, and it's kind of sort of on that border of where that is. That's another method that you can use, is you look at which lead is isoelectric. So say if AVF is isoelectric, well, it's not going towards or away, it's sort of on that horizontal. And then you just use another lead to find out which side of that horizontal it is. I think the thumb trick's easier, but it's just more discussion about how it works.
Yeah.
Shall we quickly see how Americans perceive
Let's do it.
and so on and so on? I will a couple of about the smallest defibrillators from Australia, by the way. Anyway, let's jump to the United States of America.
Hello, my name is Gina. I'm with the United States of America. Today we're talking about EKGs. So my topic is electrodes and lead placement, as well as VFib and VTAC here in the United States of America. So here in the United States, we put limb leads on limbs. That means that the QRS complex and the frequency of the reading is appropriate for that EMS setting. Now in the hospital, they could put electrodes on the core on the person's body, but they have a different setting that the monitors are used by. So left arm is anywhere from the wrist all the way up until the shoulders. So if I have one with a right arm, again, it would be the same place laterally across. So left lower leg anywhere above the ankle all the way up until the hip. Same place bilaterally across from each other, and apply the electrode. Well, she was Brady. It was Brady. Just like so. So then we would get that accurate reading. So what we're looking for is any type of frequency changes, like any artifact. And if it's artifact, we would go back over and check our placements. So here in the United States of America, during cardiac arrest, we do find VFib, and we also find VTAC. So if it looks kind of crazy, what we do is change our monitor settings to a higher reading, to like 2 or 3 on the amplitude, to see if it's true coarse VFib or VTAC, and then shock that patient appropriately. As far as VFib and VTAC, normally, of course, you would start CPR and then shock appropriately per your protocols. So that is some fine mist that we figured out here in the United States of America. I hope you guys have a great day. Bye.
Yeah, so, it's a really interesting point, and it comes back to what we mentioned before about proportion and having to go through more tissue. So it's interesting that their monitors are calibrated to use limb placement, as in like an extremity, more distal. Whereas in Australia, or at least in my service, our monitors are calibrated to use torso and torso placements.
I will leave links in to this video. both right, and it changes the research about it. Also about where the torso are moving them from. So, because Kingdom, for example, we have, and quite often clinicians are the electrodes from limb again changes the morphology, and there is a research about all, and I will leave this as a description. You can shots, not just around the good placement does not change the morphology. That's so amazing, guys. I'm not going to really because will record on that, and I will weeks of this device. So it is the world's smallest defibrillator. It phone have to do is basically snap, peel off, place the parts where they should right actually go, and then just wait, and defibrillator will do. You will get an and that's it. The shot, I think that the I've been made generate up to 21 shots, so that the devices that can do more infants as well. It can be used on pregnant patients. Please remember that ladies also use is the focus of the top electrode, and it's also not hesitate manual on the lady pediatric. Amazing. I keep doing this. And yeah, you actually have the small and even mount it on the fridge in your house, for example, or whatever may require. Also give you a fridge sticker. You can. So, most manufacturer says that it's around $100 a unit. Yeah, I think maybe the manufacturer. Yeah, team waiting for. By the way, the actual defibrillators, because it is should be available on the market late 2020. Good. So much, guys. You, our viewers, apologies for inconvenience. I really this trick with from to use it. Thumbs up for Harrison. Thumbs for thumbs down for my computer. Going to definitely. It was Group Call Live. Thank you. Recording will be on you away. See you next time.